Hey, I want to review electrocardiography and dysrhythmia monitoring right now. The cardiac electrical activity is monitored using an EKG or an ECG, either one interchangeable. And the heart's electrical activity can be monitored with a 12 lead. We can use an ambulatory monitor known as the Holter monitor, or continuous cardiac monitoring, or telemetry, which is what we're used to seeing in the hospital. There is on your Blackboard site a long review of EKGs, and if you are uncomfortable with them, please take time to do that. It's an online lecture by me done in the spring of 2012, so you can go to that link if you like. Cardiac dysrhythmias are really heartbeat disturbances in the beat formation, the conduction of the beat, or the actual response by the myocardium to the beat. We need to be familiar with cardioversion and defibrillation procedures because we need to treat dysrhythmias. We also treat them with medications, but we need to be aware of them. So we use the electrocardiograph to record the electrical activity in the heart over time, and we get that reading through wires or leads by skin electrodes that are placed on the chest, and then in a 12 lead it's also on the limbs of the patient. Continuous monitoring requires the client to be within close proximity to the monitoring system, so there is a telemetry floor that has a central monitor, and if you look up on the ceiling you'll see the little telemetry antennas that beam the readings to the monitors. It allows the patient to ambulate while maintaining proximity to the monitoring system. And that's why we always want to make sure we tell our monitor tech or whoever's watching the monitors that the patient is off the floor, because they're not going to be picked up on the monitoring system. So who gets to be monitored? Well, patients that have bradycardia, which is the slow heartbeat, heart block, where we see a blockage in the transmission through the electrical conduction system. Atrial fibrillation patients, supraventricular tachycardia, or SVT patients, ventricular tachycardia, ventricular fibrillation, of course. And the client typically presents to the emergency department and is admitted because of cardiovascular disease. Maybe they're experiencing a myocardial infarction, an MI, they have acute coronary syndrome, they may have hypoxemia, acid-base imbalances, also require patients to be monitored. Electrolyte disturbances will cause dysrhythmias, renal failure, liver failure, COPD. You will see electrical changes in the heart because of these chronic diseases. Inflammation of the myocardium or pericardium, myocarditis, pericarditis, we're going to see some dysrhythmias. With drug and alcohol abuse, dysrhythmias occur, as well as they are seen with hypovolemia and shock. Okay, when we're recording dysrhythmias, we do it with a EKG 12 lead, or with a telemetry unit or a Holter unit. Those are all connected to a machine or a monitoring system by electrodes, and those electrodes must make contact with the skin. You want to make sure your patient's clean, oils are washed off, remove any oils from their chest or limb leads, where you're going to put the limb leads. If their patient is hairy, you need to remove that hair. Some chest hair may need to be shaved on males, but we want good contact between the gel of the electrode and the skin, and that's where we're going to pick up our electrical tracing. Dysrhythmias are classified by the site of origin, like the SA node, the atria, the AV node, or the ventricle, and the effect on the rate or rhythm of the heart, with their bradycardic, which is slow, tachycardic, which is fast. If there's a heart block, a block in the conduction through that electrical system, do they have a premature beat? Is there a fluttering, a fibrillation, or is there asystole? Now, dysrhythmias can be life-threatening or benign. Every one of us has had a dysrhythmia. Let's face it, we've all had PVCs. If you've had couple shots of espresso, not eaten, gone on with your day, you'll feel that fluttering either in your chest or up in your neck, and that's a PVC that's firing off. It is not uncommon to see dysrhythmias that are benign. However, they can be life-threatening, and they're generally related to cardiac output and ineffective tissue perfusion. They are the primary cause of death in clients who have had an acute MI, primarily a ventricular MI, a left ventricle. If they've taken a hit to their left ventricle, they are more prone to sudden death and dysrhythmias. Rapid recognition and treatment of these serious dysrhythmias are essential for the nurse to recognize them, and they can have an atypical presentation in the elderly, of course, just like everything else can. So when we look at dysrhythmias here on this chart, a bradycardic dysrhythmia is symptomatic bradycardia, and that's mean where they are actually have symptoms of it, where they have lightheadedness, they may faint from it, have syncopal episodes, their heart rate is less than 60 beats per minute. Now that's going to be normal in an athlete, it's not normal in the regular Joe. The medication that we treat that with is atropine, and that's a cholinergic antagonist, and that inhibits the parasympathetic-induced hyperpolarization of the SA node. So it results in increasing the heart rate. So bradycardia, first-line drug is atropine and isoproterenol as well. If we want to use any kind of electrical management, we can put a pacemaker in these individuals. They may be candidates for permanent pacemakers. And if we have pushed atropine on the individual, we probably need to have that transvenous pacer at the bedside, or transcutaneous, pacemaker at the bedside. Atrial fibrillation, supraventricular tachycardia, and VTach with a pulse are other dysrhythmias that we're going to treat. AV and SVT are commonly seen in chronic conditions, primarily atrial fibrillation, and it commonly occurs in clients with cardiac disease and also occurs following CABG surgery, that's coronary artery bypass grafting surgery. Day 3, it's common to see a patient flip into an atrial fibrillation. So how do we treat that? Typically we will use amiodarone, adenosine, verapamil, and we may get a rapid atrial flutter. It can be manifested with palpitations. Patient will complain of palpitations, shortness of breath, anxiety. They also might be syncopal. There may be some angina. There could be presence of heart failure if they have a rapid ventricular response to an atrial flutter. Our priority intervention when somebody is experiencing an atrial fibrillation is we want to make sure that we assess for shortness of breath. A serious and frequent complication of atrial fibrillation is a systemic emboli, particularly pulmonary emboli. So we want to assess our patients for shortness of breath, chest pain, hemoptysis, which are symptoms of pulmonary emboli. Now, because atrial fibrillation there in the atrium is fibrillating, and it has the ability for the blood to clot in there that can passively go down into the ventricle, and then we can have small clots fire off, they're also at risk for stroke besides pulmonary embolism. So that's the other thing we want to pay attention to, is if they have any signs or symptom of stroke. Which makes us think, okay, so what are we going to do about it? Well, what patients who are on atrial fibrillation typically are going to have anticoagulant therapy provided for them. So we need to think about all those things that if they're at risk for emboli, we're going to use anticoagulants like heparin or Lovenox or warfarin, Coumadin. So a patient who's in chronic atrial fibrillation they are at risk for systemic emboli happening. It could be a pulmonary emboli, it can be cerebrovascular emboli event, so they are going to be on an anticoagulant likely. They can also be treated with cardioversion, and I'm going to discuss that in the next slide. Pulseless, or pardon me, ventricular tachycardia with a pulse. If we have PVCs 3 in a row or greater, that is called a run of VTAC. Typically, we're going to report a run of how long. Like they might have a run of 6 or 7 in a row. Sometimes the patient doesn't even feel it or know that it's happening, but we can see it on the monitor. Those are also treated with the amiodarone, adenosine, and verapamil. We're going to have another 10-minute topic on meds coming up here, so I'm not going to go into a huge detailed information on that. Pulseless VTAC or VFib, meds we use to treat amiodarone, lidocaine, and epinephrine, and those are pushed quickly, and a code is called if we have a pulseless VTAC or VFib. Cardioversion and defibrillation. I love this little slide here. This is from the Nursing Education Consultants. I got it a number of years ago, but it's a great slide. Cardioversion is the delivery of actually a synchronized direct countershock to the heart, where defibrillation is a delivery of unsynchronized direct countershock to the heart. Defibrillation stops all electrical activity of the heart, and it then allows the SA node to take over and reestablish a perfusing rhythm. That's the goal that's behind it. So the earlier that we can defibrillate, the better. We want to get in there and defibrillate as early as possible for patients who need to have a defibrillation. So let's talk about that. Who needs that? Cardioversions are indicated. They're elective, and they're usually used in the atrial dysrhythmias, SVTs, and then VTAC with a pulse will do that as well. It's the treatment of choice of patients who are symptomatic. Somebody who has been in chronic atrial fibrillation, they're not going to get cardioverted. They've probably been in it too long. But if it's they've just flipped into from a sinus rhythm into atrial fibrillation, cardioversion is the treatment of choice. And defibrillation is for ventricular fibrillation or pulseless ventricular tachycardia. This is a code situation we're actually defibrillating. And the outcome we're after is that the heart's going to return to a normal rhythm once we've countershocked. Patients who have a fib of an unknown duration, we need to make sure that they're anticoagulated before we cardiovert them, because once we flip them back into a normal sinus rhythm, they're going to have atrial kick will happen again, and then they're more likely to throw a clot at that point. So they need to be anticoagulated prior to the cardioversion if they have had the AFib for an unknown duration before they come in. Now, if they've had AFib for years, they're not going to get cardioverted. So this is a cardiologist call on whether or not the patient's a candidate based on the duration of the atrial fibrillation. We want to prepare our patients by getting an informed consent, making sure they have oxygen on them, document the rhythm they're in, make sure we have a crash cart on hand. They need an IV flowing. We're going to give them sedation. They're getting a shock. This is going to hurt. So we have to give them any anti-dysrhythmic that's prescribed, and other prescribed medications if the physician wants it. We're going to monitor the patient in a lead that gives us an upright QRS complex so that we can have a really good look at what the ventricle's doing, because we're going to sync with that QRS complex, synchronize with it. As with defibrillation in cardioversion, we need to make sure that all staff, all bystanders, are clear of the patient. the equipment connected to the patient, and the bed when the shock is delivered, because we don't want inadvertently to shock the respiratory therapist that's standing there. So we all do that. I'm clear, all clear, we're all clear. You're clear, I'm clear, you're all clear, however the mnemonic goes. But we want to make sure that they're standing clear. So to actually cardiovert, you have to activate the synchronizer button in addition to charging the machine. So you press the sync, you press the charge machine, and that allows for the shock to synchronize with the client's underlying rhythm. It turns the eyes on, so to speak, so that the machine can see that upright QRS complex. If we don't do that, we could shock the patient and put them into a lethal dysrhythmia and cause ventricular fibrillation. So during cardioversion, there must be synchronization. If we have a systole or other pulseless rhythm that comes from it, we're going to be starting CPR, defibrillate immediately. If we have ventricular fibrillation, remember early defibrillation is the best, and we're going to monitor our patients following for any embolization or systemic emboli, pulmonary or systemically. After their cardioversion or their defibrillation, either or, we're going to check their vital signs, we're going to assess the airway, get a post-EKG, provide the patient and the family with emotional support, reassurance, document the rhythm that they're in. Ideally, if we're cardioverting them out of atrial fibrillation, we're hoping we have a sinus rhythm on the end. And we also want to record the number of defibrillation or cardioversion attempts, what the energy settings we're at, how many joules we use to cardiovert or defibrillate them, the client's condition and state of consciousness following the procedure, and then we want to check their skin under the electrodes because we can burn them with that shock. We want to make sure that the patient post-procedure knows how to assess their pulse so that they can see whether or not they're going back into an atrial fibrillation if they've been cardioverted out of it. Classic atrial fibrillation is an irregular pulse, and we want to make sure that they know to report any palpitations that they feel, or if they feel irregular pulses again. So that would mean they would have gone from the sinus rhythm that we converted them into it back into atrial fibrillation, which is not uncommon. I don't have a percentage of success rate, but it's not uncommon to see them go back into it. Complications of a cardioversion, like I said, embolism. It can dislodge clots. It can potentially cause a pulmonary embolus, and the signs and symptoms we're looking for that are shortness of breath, chest pain, air hunger, decrease O2, a CVA if it goes systemically up into the head. We're going to see a decreased level of consciousness, slurred speech, muscle weakness, paralysis. And if that clot went off into the coronary arteries, we would see an MI, and therefore we would see chest pain, ST segment depression or elevation. So we're going to be making sure that we get some therapeutic anticoagulation on that patients who have had the dysrhythmias. And another complication could be decreased cardiac output or heart failure. It could damage the cardioversion itself, could damage the heart tissue and impair the heart function. So we're going to be looking at cardiac output by assessing for hypotension, heart rate. It could be increased, it's trying to compensate. Syncope, another sign of failure or decreased cardiac output is syncope. And heart failure signs and symptoms we'd be looking for is shortness of breath, maybe a productive cough, edema, venous distension, JVD. So patient would probably be going on medication to increase their cardiac output, so like an inotrope of some type. That's going to decrease the cardiac workload, but increase their cardiac output.